So thinking back about our patients as we're assessing them, we've completed the NIH stroke scale. We're doing our initial assessments as they're calling all the rehab professionals in and the labs coming in to do lab work. A patient may have trouble attending to or processing information, which again can affect their comprehension and their communication. So we receive information through our senses. So we have auditory, visual, we have our sensory receptors for tactile, gustatory, taste, etc. And how we receive information directly influences how we comprehend and how we recall it. So I'd like to look at each one of these possible deficits that you may come across with your patients and your patients may present. I want to give this as a caveat in that if those of you who have teenagers, you will find that these disorders are not solely relegated to those who are recovering from a stroke. That I have survived 2 teenagers growing up, and I think the intermittent processing one is huge. So let's talk about each one. Slow rise time. You start talking here, but your patient starts comprehending here. These are the patients that miss the first step of a 2-step command, or they miss the first part of your utterance. And they have what we call a slow rise time. The brain starts moving slowly, and they start processing your information slowly. Intermittent processing is they might start processing on time, but the processing cuts in and out. So they might hear bits and pieces or portions of what you're saying. Again, teenagers. And then information capacity deficit. That is where they might start processing what you're saying, but their processing ability drops off towards the end. So these are the patients that might miss the final step of a 3-step command, or they recall the first part of a paragraph that you're having them remember, but they forget the last part. These are also the patients with information capacity deficit that perseverate. And I'd like to really highlight that because I feel that perseveration, when we see that motor perseveration or verbal perseveration in our patients, at times it's something that we cause, because they might be able to understand this much, but the amount of information we're giving them is this much. And we're overtaxing the system so the brain can't move on. And it's like that broken record that's skipping, it's stuck. Those are the patients that reply yes to pretty much every yes-no question that you give them. They might perseverate on a motor command or an action because they are overloaded. Their capacity deficit has been met, and we keep on taxing them. This is a great example of where we need to back off and give them some strategy and give them some rest. So if you have patients that have any one of these processing disorders, there are some strategies that you can use as a clinician or as a nurse or medical practitioner to work with them. First of all, if they have a slow rise time, bottom line is eliminate distractions and establish direct eye contact using an alert cue such as their name, or I touch them and say, ready, to make sure that they're looking right at me before I give my verbal command or my information. And sometimes I won't start talking. I'll touch them, and I'll wait for them to actually look at me, and then I start talking right away. For intermittent processing, you can use verbal emphasis on the words that are important. Raise your right hand, point to the ceiling, then to the floor. Vocal emphasis can help the patient understand what you're saying. And ideally, keep it short. If the person can't understand much, the longer we talk, we're just causing them to have poor comprehension, poor memory. With information capacity deficit, ideally limit the duration and the amount of information that we provide to our patients. For example, when I'm asking yes-no questions, if I see a patient comprehending yes-no questions below 50% and that they are perseverating on yes, I might have to stop and give them 10, 20, 30 seconds in between. So I might start at 10. I ask the question, 10 seconds, alert, ask another question. Does their comprehension go up? Because I compensated for the capacity deficit. Sometimes you have to go 20 or 30 seconds. And by doing that, they're comprehending what you're saying. You're not going to have to repeat your information because you've compensated for their deficit. Does that make sense? It's an easy thing. Yes, in therapy, it seems like it takes forever because when you time 20 seconds, it's forever. But if it helps them comprehend better, it's totally worth it. Language and memory. Because our brains are so interconnected and that there's several steps to get from A to B, looking at how each step functions and the possible risk of dysfunction at each level impacts what happens later on. So first, we have to attend to a stimulus, and I'm thinking auditory right now. So we perceive it auditorily. Our brain needs to focus and attend to it. It processes it using those information processing strategies and techniques. Then it must comprehend it, to interpret it, to remember it. All of these steps, there's the risk of dysfunction after a stroke. And it can influence our verbal and nonverbal learning and memory. So think of that when you're giving your commands or you're doing your assessments. At what level do you notice that your patient is having difficulty? Are they attending to what you're saying? Are they processing it? Is their processing slow? And I might tell a patient, your thinking speed is about 20 to 40 miles an hour. Let's get up to speed limit here. Or if they're trying to think too fast and they're making lots of mistakes, we have to slow it down. How they interpret the stimulus, again, depends on our presentation, but also what their brain is capable of doing. So that's part of therapy. And then there's memory. We know that there's different types of memory. We have our working memory, our linguistic memory, our procedural memory. That can be affected at any level and impair the patient's performance, again, in therapy, for recalling their medications, for safety awareness. Language and memory. Let's talk about this as it occurs after a stroke. So research into language and memory has really advanced over the last 10 years. And one used to think that they were entirely separate, that you had language and then you had memory. You had language and then cognition. They're finding now that it's not as separate as one thought. And researchers have shown that if a person has a conduction aphasia, where there might be a mixed receptive and expressive component, that these are individuals that may have decreased verbal short-term memory. So it's not, you're saying something, it's got to transfer from comprehension to action, but they don't remember it, right? So thinking about that is going to influence how we test our patients and how we treat them. Conduction aphasics may have more difficulty with their verbal memory, whereas patients who have more of a frontal lobe involvement near the Broca's area, they are going to have more of a dysfunction affecting phonological memory, or how speech sounds, how speech is produced. That makes sense, doesn't it? Because they're the ones that are talking and having trouble articulating the sounds. That's the hallmark of an apraxia. So they have found, the researchers have found that there's more of a phonological memory disorder in frontal lobe Broca's aphasia. And then temporal and parietal. Makes perfect sense that these patients who have damage or infarcts in the temporal parietal lobe have non-verbal short-term memory deficits. That brings to mind, for me, my assessment when I go in to see a patient can't always be verbal. I need to do a non-verbal assessment. There's the test of nonverbal intelligence, the TONI, that perhaps we need to select some items when we're doing our initial assessments or our treatments. So knowing that patients here are going to have trouble with their nonverbal memory, it's going to influence how our treatment is built. So again, we have to attend to, temporarily store the information in order to process it, remember it, and then comprehend all of the above. So dysfunction at any of those levels will affect performance down the line. The interesting part, I'm really excited to say that we are partnering and we're waiting for an R01 grant approval from the NIH to test the test. And at present, there is no formal measure of assessment of language in short-term memory and aphasia. Temple University has been working on this for 5 years. And they've selected Christiana as one of their sites in partnership with the University of Washington to be a testing site for the Temple Assessment of Language and Short-Term Memory and Aphasia. So this test incorporates verbal measures into acute care assessments. And I'm excited to be a part of that. And this will be rolled out into our 5 outpatient sites. So we'll be testing the test for our patients. That's pretty exciting. How many have seen this and read this book? Really? You should go out and get this. Because if you're an acute care therapist or you work in rehab at any level, this is a book that probably will change your approach, and it did mine. So Jill Bolte-Taylor, it was a neuroscientist who suffered and survived a stroke, 8-year recovery. The stroke affected her at age 37. The book describes the day of stroke, when she got up, she was in the shower, and she realized that she couldn't really move her hand, and realizing, oh, I'm having a stroke. It describes her attempt to recognize 911 and call 911 on the phone. It describes her perception of when medical personnel would come into her room, start talking when they hit the door, and she's saying, in her brain, she's saying, wait, what did you say? And so this is a book that I really encourage you, if you could read it. I think it'll help you understand and be more aware of your communication style. For me, I'm obviously a fast talker. So I have to check myself before I go into the room. And I literally stop, pause, I collect myself. So when I go into a room working with a patient who I don't know their level of communication yet, I make sure I slow down. I make sure I'm using those strategies to give them the benefit and help them comprehend. But looking at this, we are strategies that hopefully you'll take home today on how to better communicate with individuals who have aphasia. So first, get their eye contact. Watch their body language and facilitate your use of gesture, encourage their use of gesture. Communicate without background noise. Turn off the TV. Pull the curtain if you're in acute care. Keep your voice at a normal level. You don't need to talk really loud because oftentimes they may not have a hearing problem. Communication can be simple and short. Emphasize your words, as we talked about, and speak slower, not like I'm doing now. Give them time to speak. Oftentimes it takes them some moments to gather their thoughts and attempt to produce them. Encourage their communication with drawing or gesture. I'm like, I need you to talk with your hands. Yes, no questions or binary choice is also a good suggestion when working with our patients. And then trying not to downplay any errors. I really encourage that these strategies help you. But aid it. Aid it is wonderful, and I really encourage us to be mindful of using this when we're working with our patients, especially those who are recovering from stroke. So thinking about the processing information I gave you and the communication strategies I just talked about. Acknowledging the patient, introducing yourself, making sure you have direct eye contact can help with a patient recovering from a stroke. Talking about and explaining, short, direct, with vocal inflection. They'll help understand them. They'll understand you. And then T, thanking them. Thank you for letting me work with you. Shows compassion. It's a little bit, but it goes a long way. This is perfect for our patients at this level and any level. We do have many resources available to us from the Academy of Neurogenic Communication Disorders, for the Aphasia Hope Society, and the Stroke Association. Check these out. There's some great tools for communication. We do have World Stroke Day coming up, so you can celebrate. I have many resources regarding communication and aphasia. And I'm done. On time.